This is Patrick, and Ekawit is sitting next to me.
Yes.
Hello.
Are you ready?
We are as ready as can be. Thank you.
Cool. So, in the coming maybe 40 minutes, Dr. Ashish Babhulkar will demonstrate his skills in arthroscopic bony Bankart repair. We cannot see you, Ashish.
Thank you. Thank you. Let's get started. Thank you, Patrick, Ekawit, and also the team, Bancha and his team here. They've done a fantastic job. Thank you for this invitation. I think it's very impressive that we can have this cadaveric workshop at the RCOST meeting here. So I have just had a go and I have prepared the lesion. So we'll just try and enter the joint.
Can hold on? Can we see the shoulder from the outside view, please?
Yeah. Is that okay?
Yeah, cool.
Perfect.
Yeah. We also need the inside view. Yes. Thank you.
Perfect.
How many portal you plan to use?
Three, if not one extra, maybe. So I've had the liberty. This is a longeter biceps. This is the glenohumeral joint. And you can see a nice, crazy Bony Bankart. It's a modest size Bony Bankart, but this is typical of what you would see. And apart from the diagnostic sign, then I think we should proceed directly to the surgery. So this is my anterior superior portal. This comes through the rotator interval and is very close to the longeter biceps. But I would like this to come high and the ability to see everything here. But this will be my viewing portal. So I'll just, if you permit, switch. And I need an exchange rod behind here and a knife as well. Knife. No. One missing. That'll do. That's okay. Yes. Cannot? Okay. No, it's okay. Don't worry. It can. Oh, it's okay. I'll manage. It's okay. We can find a way out. The fluid. The pump fluid has fallen off. Oh. Just connect here. So we're switching to the anterior superior viewing portal. Just coming in there. Yeah. And then, can I have the knife and a 8 mm cannula? First the knife. Yes. Yes. So we just make that posterior portal. Thank you. So Sitam is with me and he's done a good job, and that's my 8 mm cannula in the posterior portal, and that should work well. You can see the straight line here. We will eye-stonks the suture retriever, atraumatic suture retriever, yes. And no, so I have this standard portal here, which is the subscap portal. Okay. And I'm just going to check the lesion here. I've had the liberty to prepare this all the way down here, and we can see the subscap down here as well. So I think our entire preparation looks good. There is still some continuity here. So the labrum is in continuity. It's sometimes very difficult to pick up the labrum, pick up the bone fragment. So you can always pick up the labrum here and pull this up and see whether this fragment is stiff or well released. And if it is well released, then this is how it's going to come in and sit here. I like that. So I think we can proceed. Now, the technique that I use, I'm a very lazy person. I use a very easy, simple technique. So let's have the tap for the, yes, helicoil double loaded. So sometimes I use the helix, which has sutures. The only problem with this suture, this technique, is the sutures are through the joint. Now, whichever portal that you use, you want to have an anchor going on the medial face of the glenoid. So here I've made a trans subscap portal here under vision, and I'm going to put in this anchor on the medial face, somewhere at the middle of the lesion. Yes.
Ashit, what do you mean the trans subscap portal?
So the trans-subscap portal is a very low portal here that comes through the subscap. The reason I can use the standard anterior inferior subscap portal for the same, but then I use an all suture anchor because I need a curved drill guide to reach all the way down. Now in a cadaver bone, an all suture may not hold well, so that's why this is the plan B alternative. But for this, because the tap and the anchor come in straight, it's important that I reach the medial wall. So I have a suture that goes through, I have a knife, a needle first comes in through the subscap, and this has come through the subscap. Okay?
Thank you.
That gives me access to the medial wall of the glenoid. If it's a young patient and the bone quality is good, keep the cannula down. Thank you. Yes. Then I will use all suture ankle. I will not make a trans-subscap portal, which is much more riskier. I would then use a curved drill guide to be able to access the anterior wall of the glenoid. So this is a helicoil 5.5 double loaded anchor. So today I'm going to present you the simplest technique, just one helicoil because it's a modest bone banker, bone fragment. When it's a much larger bone fragment, then I would use 2 of these anchors. Then I'll have 4 and 4 sutures here. What is very important, because you're dealing with a fracture surface, it's important that your hold should be good. In this case, I have a very good hold. And this technique is the most simplest technique ever. The only hitch here is to be able to retrieve these sutures underneath that fragment. So that is the technique. So now, give me a suture retriever. I'm going to pull out the sutures and park them here posteriorly, because the whole aim here, we don't need to. Hero does a technique where he uses a bone needle to go through the bone fragment. I don't have the guts or the testosterone to do that, because sometimes this bone is fragile and I can fragment that bone, and if that bone gets fragmented, then I'm in deep trouble. So here, though, I need this one, the blue one, right?
Ashit,
Ideal suture shuttle. Yes, please.
can we see how far you go for the glenoid neck?
Yes, sure. Give me the probe or eye stones. Okay, here we go. Yes. So that's as far as I go. Okay. Not too far, but you must understand the trajectory of this anchor is inferior and medial. That is very important. You don't want to devastate the cartilage by coming in parallel. So it has to go deep inside in this direction. And if I have a full length Bony Bankart, then I'll put another one here. And that's easy to do here. Okay. As I said, if you have a curved drill guide, then you don't need the trans-subscap portal. But the only difficult thing in this procedure is to retrieve the sutures underneath the labrum. And once that is done, then everything is over. It's very simple. Then it's just a knotless suture anchor that will do the job. So this is the toughest part here. So for this, you need a special indirect suture shuttle which will go all the way around. Now we must try not to break the ring. We must try not to break the ligament or the bone fragment. So here, what I'm going to do is pass this down here. Okay. So here I'm picking up the IGHL, labrum, and trying my best to come below the fragment. That is very important. If you can do that, then this makes this surgery absolutely easy peasy. And that's why I'm using an ideal suture shuttle for the same reason. It has to go around the full fragment like this. There you go. And Sitam for me is going to pick this up. Thank you. Gently. Because we have 4 sutures in the posterior portal, we can get all of them wrapped inside. Let's have the green ones. Can you hold both in both hands? One each. This one, blue. Yeah. One. Just no. Yeah. Yeah. One second. Hold both. Hold both. Hold both of these. Hold it. No. Hold both. Now unspin this. This is got. No. Spread your hands. One in right, one in left. One in right, one in left. Yeah. One sec. Take this out. So, yeah. Unravel these so that you're not locking them in. Now gently pull the right one for me. Yes. I want the right one to go inside that. So while he's passing that, hold this in your hand, leave that, and I'm going to come out here. If you're lazy, you can take one white and one green simultaneously. Use a mosquito. Yes.
So Ashi,
Yes.
so can you explain a little bit about what is your upcoming plan, the configuration of the suture anchor that you are going to place, right? So you put in the middle row anchor already, right?
Yes.
So what's next?
So once I retrieve all these 4 sutures underneath, then I'm going to do a knotless anchor. I'm going to use a micro raptor today, and that's a knotless anchor. So I'm going to pick up these. So I'll pull the one pair of the green sutures and pass them in the superior glenoid, and one pair of the white sutures in the inferior glenoid. Always do the inferior sutures first and pull them up, because that's going to give you a shift and pull the fragment back into its reduction mode. And then, sorry, there's a trick on how to maintain the reduction, because the whole idea is, because it's a big fragment, you must never do a single row, because the single row will flip the fragment and then it will not have enough contact. So this is my second one coming in. And again, make sure you're below the fragment like this. That's the only difficult part of this procedure. Sorry. Yes. And let's have that other green suture come out. Yeah. No. Green. This one. Yeah. It's okay. Yes. Gently. Cannula. Thank you. These guys are very experienced. My team here, they are holding the cannula each time my suture is coming out. So I'm working with the A team here. And that's good, because that reduces my stress levels significantly. Plus, you need a patient that's as cooperative as this cadaver. That's not always the case. Okay, now. So having 2 pairs of sutures here, I've seen them come in. I'm going to take the next bite just there, so that you don't want to mix them up. So your top suture should not go below the bottom suture, because then they will not slide. The whole idea of using the knotless sutures, they have to slide imperceptibly. If I use 2 double loaded anchors, then I need 3 microraptors here. But today we plan to do 2 microraptors. So we got past 3 of the 4 sutures, the last one to come up here. And see here. So here, this is wrong, because I'm going, watch this, I'm going, one sec, sorry. I'm going, see, do you see that? That's wrong, because it's going past that inferior suture. So I have to be very perspicacious and ensure that, yes. So they have to all come out linearly, one after the other, without crossing each other, so that they slide well. Let's have the microraptor ready with the drill guide and the drill. Cannula, please hold the cannula for me. Excellent. So this job is done. Now, I don't want to mix up my sutures. So can I have an eye strong, the suture retriever? Yes. And just lift the head out for me. Yes, thank you. So those are my green sutures, which are the lower sutures. Just so that I don't mix them up, I'm going to park the white sutures away without damaging. Just here. Okay. Perfect. Let's have the drill sleeve for the microraptor. Yes. Actually, this one. We should have passed a cannula here, but today I'm going to give it a go. So I would normally put a cannula here in the anterior superior port. Oh dear. Can I have a cannula? The orange one, yes, and a suture retriever. Suture retriever first. No, don't put that. Just give me the empty cannula and give me the suture retriever. Give me the empty cannula. No, here. Just like this. Yes. Perfect. Pull the cannula down. Pull the cannula down. Yes. Perfect. If you hold the suture for me. So technically we should be done in 12 to 14 minutes if this step goes through well. Thank you. There you go. Give me the suture retriever again. The one error I have done is I have picked the wrong suture. So here we have had minimum handling of the labrum and the bony fragment because both tend to be very fragile. As I said, always take the green or the inferior suture. Please hold my cannula for me. Always choose the inferior suture first. Now we'll do the drill. So the microraptor is great here because it has a small profile and this is my inferior suture, so I'm going to go high here, just around there, at the top end of the fragment, go, and this one goes right through. If you use something like a, helix, which are sutures that are going to dissolve, then there's nothing wrong with having, yes please, thank you. Smart. So they've loaded this for me. Please push the cannula down. I'm going to remove my drill sleeve. It's very important to push the cannula down so that you're not losing the suture hole there. Yes, please go on. Yeah, go. Excellent. Go on. All the way. Can you just pull the blue sutures for me? Yeah, just tighten them up. Yeah. Yes, nice. Love it. Perfect. Go. Excellent. That'll do. Enough. Yes. Knock it in. Yes. Okay. One tap. Enough. Now you can roll there's a black knob at the end. You just want to tighten it. Yes. So that's going to cinch the microraptor together. So the sutures are locked now. And then I can just pull this out. And as easy as that. Do you want to take a cutter? Sitam? Yeah. Thank you. Yeah. Just take care that, the white is not. Okay. Suture retriever now. Can I have a probe, please? There's one other step that I needed to show you here.
So Ashi, right? You put the microraptor
On the face.
quite on face. Is it
Yes.
your routine or because of the osteoporotic bone that you anticipate in this
Yes.
cadaver?
Always. But
Always.
if you do that, then only you can get a hairline reduction. As I said, if you use a helix suture, then this is all going to dissolve anyway. So the one thing to do here is sometimes this fragment comes up and becomes proud. So you can just level this down from behind and your assistant can bring in a hairline reduction, which is imperceptible. And it's like, So we'll leave the probe there behind and we're going to bring in right there. See, the profile of the microraptor is just 1.8 mm. So that also works well. Go. Excellent. Thank you. Okay. Now push the cannula down. Yes, perfect. Thank you. And then, one sec. Pull the sutures, please. Just knock it a little. Knock it. Yes, enough. Now lift the cannula and pull the sutures one at a time. Gently. Yes, 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 yes. Perfect. So that's bringing about the reduction. Perfect, perfect. Lovely. Go, go, go. Excellent. Now the black knob. So you just tighten the knob. That's it. And Bob's my uncle. Here. Cutter. I'll take the probe now. Lift the cannula up so that. No problem. Excellent. Okay. So let's evaluate what we have done. So you can perceive that there's a shift. This all is tightened up. You can see all this IGHL which was down there has been pulled up because we pulled the green band first, and we've got the labrum repair done automatically. Now it's a hairline reduction of the labrum here. You can hardly see the fracture line here because the indirect suture shell technique tensions them well and sitting there nicely. So there's a labrum tear here remaining. I'll use my third microraptor here without, so I'll need a suture to pass in first.
So, Ashi, right? So
trust
for
it.
these two microraptors that you put in, right, does it matter whether you put the 5 o'clock first or the 3 o'clock first? Because not right now you put the more proximal one first, right?
So I put the distal one proximally.
Yeah,
So
exactly.
so that's very critical. You reinforce a very good point. It's important to have a shift from inferior to superior, and that's why the inferior bite should come in superiorly, and the superior bite should go in inferior later.
So not the other way around, right?
Absolutely not.
Okay, cool.
Absolutely not.
Thank you.
Thank you.
Actually,
Yes, Ekawit.
how do you choose which one you use, the knot or knotless system, and whether it's different or not?
So you could use any knotless system on the face. The reason I use the Microraptor, it's very small, 1.8 mm, sinks beautifully, and takes two sutures very nicely. If I use the helix anchor medially, those sutures which are orthocord will actually dissolve 50% after 6 months. And then even if your sutures are going across the joint, it still doesn't matter. So you can play and choose. You can use any double loaded anchor on the medial side as long as you have a very good hold. So in osteoporotic bone, I might use sometimes PEEK, or I might use a titanium 5.5 in very elderly. You see, when elderly patients dislocate their bones, they are more likely to have a bony Bankart rather than a simple Bankart. So then I would use a titanium 5.5 anchor medially. And on the face of it, you could use either the Microraptor or a push lock, whichever system suits you. Or there's a cinch lock by Striker as well. So I've used all of them with equally good results.
And in case that the bony piece is quite wide
Yes.
or wider than the
Yes.
suture hook, what's your technique to suture around the
Okay.
wide
I was
fragment?
anticipating that. So I have here a sixter or a clever hook. So can I, yeah, here? Can you see this? Yeah. So that's a sixter or a clever hook, and that's much more rigid. You don't want to break this suture there, and you have to then compulsorily go through the subscapular. Yes, yes. Subscapular. So that's a plan B. I agree. I told you, that is the most difficult step, to retrieve the sutures from underneath the labrum and the bony Bankart. You can start with your anchor going in medially directly, but then you're blinded by the labrum. You don't want to damage the labrum. So I pass the anchor lateral to the labrum into the medial glenoid, and then all you have to do is take your 4 sutures underneath the labrum. That's the only tough thing about this procedure. It's very similar to what Peter Millet does, but it's just simple. Once the sutures are passed, then it's easy peasy, because then all you have to do is put in your indirect suture shuttle and get the sutures across, and then your knotless suture anchors are going to do the rest for you. Because you're dealing with fragile tissue and the bone fragment sometimes isn't very good quality. You see, today we have hardly ever handled any of the tissues here. So if you don't handle tissues, then the chances of damaging that bone fragment is very less. Hiro Suga has far better skills than me. That's why he'll go through the bone fragment. Now that's a very strong repair. And he has a bone stitcher for that. Just a plain suture, yes. Orthocort, ultra braid. Yeah, thank you. Thank you. Eye stone. Hold the back suture.
Any question from the floor?
Eye stone, this side.
Please.
Let's have a microraptor ready. So this is translabrum, just here. Hold the cannula for me. Thank you. So this top end allows us to close the top shelf so that it's a watertight repair, and it also ensures that there's a seamless repair between the bottom to top. Yeah, cannula down. Thank you. Just going in. Oops, I missed that. Yes, okay. Just a little tap. Yeah, now pull the sutures. The previous knotless anchors used to be quite big in size, 2.3, 2.4 with the Microraptor. Because you're doing 1.8, it's as, okay, go on, knock it in. Just takes the difficulty out. Yeah. Just a little. Just one more tap. One more. Yes. Black. So don't forget to tighten the black knob, because that will cinch the two parts of the Microraptor, and then the suture gets locked, and then the sit arm will cut the sutures for me. Excellent. That's your job done, and maybe we could show it to you from the back portal, because we saw it. And that's your final repair. And you can see the shift from inferior to superior quite nicely.
Beautiful.
Thank you very much.
Any questions from the audience? If not, please join me to give a big round of applause to Ashish Babhulkar. Thank you.
Thank you.
Thank you.
Cheers.
Thank you very much.
Thanks for the opportunity, Team RCOST. Really appreciate my surgical team here, Dr. Sitram and team. Thank you. Great
Thank
job.
you very much.
Thank you.
Okay. Thank you very much. In 5 minutes, we will have next
Okay. For-
demonstration. Okay.